Postpartum depression, PPD, and postpartum psychosis, PPP, are distinct yet interconnected conditions that can affect new mothers. Here are 15 key differences between them. 1. Nature of condition. PPD. It is a mood disorder characterized by prolonged feelings of sadness, anxiety, and exhaustion after childbirth. PPP. It is a severe mental illness characterized by psychosis, which involves losing touch with reality, hallucinations, and delusions. 2. Onset. PPD. Symptoms typically develop within a few weeks to months after childbirth. PPP. Symptoms usually appear within the first 2 weeks postpartum, often abruptly. 3. Prevalence. PPD more common than PPP, affecting around 10 to 15% of mothers. PPP much rarer, occurring in approximately 0.1-0.2% of new mothers. 4. Symptoms. PPD symptoms include sadness, irritability, changes in sleep or appetite, feelings of guilt, and difficulty bonding with the baby. PPP symptoms include hallucinations, often auditory, delusions, often paranoid or grandiose, confusion, rapid mood swings, and severe insomnia. Severity. PPD generally less severe than PPP but can still significantly impair daily functioning and bonding with the baby. PPP considered a psychiatric emergency due to the risk of harm to the mother or baby. 6. Risk factors. PPD. Risk factors include previous depression, hormonal changes, lack of social support, and stressful life events. PPP. Risk factors include a history of bipolar disorder or psychosis, family history of PPP, and significant sleep deprivation. 7. Treatment approach. PPD treatment often involves therapy, like cognitive behavioral therapy and medication, such as antidepressants. PPP requires immediate hospitalization and treatment with antipsychotic medications to stabilize the mother's condition. 8. Duration. Symptoms can persist for months if untreated, but generally improve with appropriate intervention. PPP. Without treatment, symptoms can worsen rapidly and lead to dangerous behavior. With treatment, symptoms can improve within weeks. 9. Impact on mother-infant bonding. PPD may affect bonding but typically allows for some level of interaction and care for the baby. Often leads to significant impairment in the mother's ability to care for or safely interact with the baby. 10. Awareness of illness. PPD. Mothers are generally aware of their feelings and recognize they are experiencing depression. PPP. Mothers may have impaired insight into their condition and believe their hallucinations or delusions are real. 11. Risk of harm. PPD. While mothers with PPD may have suicidal thoughts, the risk of harming the baby is low. PPP. Mothers with PPP may have thoughts of harming themselves or their baby, necessitating urgent intervention. 12. Recovery. PPD. Recovery is common with appropriate treatment, and many mothers return to their baseline functioning. PPP. Recovery may involve ongoing treatment and support, and some mothers may experience recurrent episodes. 13. Social impact. PPD can strain relationships and affect the mother's social interactions, but typically does not lead to social isolation. PPP often leads to significant social withdrawal and may strain relationships due to the severity of symptoms. Postpartum recurrence. PPD. Mothers with PPD have an increased risk of recurrence in subsequent pregnancies or during other stressful life events. PPP. Mothers with a history of PPP may require careful monitoring and planning during future pregnancies due to the risk of recurrence. 15. Public perception and stigma. PPD. Generally more recognized and accepted as a common postpartum condition, reducing stigma. PPP, less understood and often associated with fear and stigma due to its severe nature and potential for harm. Understanding these differences is crucial for timely recognition, intervention. Thank you. Have a nice day.